Okay, right now I'm going to talk about the action potentials and the differences between contractile cells and pacemaker cells. The first thing to really know is we only really have like a certain amount of pacemaker cells. Those pacemakers are first our SA node, then the AV node, our bundle branches, we also have our Bachman's bundle, and our Purkinje fibers. And so if we look at, this is going to be a pretty mid drawing of the heart, but we have these are our atriums and these are our ventricles, and then obviously left side and right side of the heart. This is going to be deoxygenated because it's been going through our body, and this side will be oxygenated because it has been through the pulmonary and done capillary exchange. So what happens, we have our SA node here, and then we have our AV node around here, and then this will send a signal. This is our Bachman's bundle. It sends it so the atriums contract at the same time. Then we have our interatrial signal or whatever. And then the next one is the bundle of His. I forgot about that one. Bundle of His. And then this goes like here, gets it from the AV node, and then we have a signal that goes like that. These are our Purkinje fibers. Okay, and so these are all kind of the pacemakers. The SA node is the fastest. It wants to run around 100. I don't know the exact numbers for everything else, but since SA node's the fastest, it's the pacemaker of the entire heart. Okay. So now we'll go, I'm gonna draw two cells, and you'll see the main, the differences and how they affect each other as they go through. So we have right here, I'm gonna draw a cell, and then right here, I'm gonna draw another cell. This is our contractile, and this will be our pacemaker. Intrinsically, the way they taught it to us was contractile and then pacemaker, but for me, I'm gonna do it kind of chronologically in the right order, and so I'll show you. And then we have kind of what this looks like on an action potential graph. Okay, the first thing that we're gonna have is these pacemakers don't have nearly as low of a resting membrane potential. And so their resting membrane potential is about right here. This is -60. And then their threshold is right here at about -40. And then when they have reached their action potential, they'll raise to about +40. And so this is our SA node. what's gonna happen is we have these kind of weird, kind of funny channels. Those are called our funny channels, quite literally, or HCM, which is has to do with our cyclic nucleotides and stuff. And so what's coming in here is sodium. And that's kind of weird, and that's what makes it our pacemaker cell. Sorry. So we have our resting potential, and then what's gonna happen is it's gonna go up from that, because those funny channels are gonna be slowly depolarizing our pacemaker, which then activates this is our L type, or our T type, sorry. Let's do these in green. Our T type calcium. And that will keep bringing our membrane potential up, as well as the funny channels, until it hits our threshold. And then what happens is our L-type channel is open, and that creates a huge, that's our action potential right here. And since it's calcium repolarizing or depolarizing the cell instead of sodium, what actually happens is these channels are a lot slower. And so the action potential isn't nearly just like up and straight down. It takes a lot longer for it, so it kind of just like stays contracted for a little bit longer. And it doesn't go up and down as fast. And that's another big difference between these cells, is the calcium is the one that depolarizes everything. This is calcium, not sodium like we're used to seeing in skeletal muscle. And then after that, we're gonna have kind of our normal this would be our potassium leaving, and that's going to repolarize. And then, believe it or not, our funny channels go right back to work. We get our T type, and then it triggers our L type. And we do it again. And it does it over and over again. And this is the pace of the contraction on how that works. And what's kind of cool about that is these two cells are connected by a gap junction. This is our gap junction. And then we also have I draw, this is a desmosome. And so what happens here is this positive bong that's sent conducts down the gap junction, and then it triggers the contractile cell. And then when that contracts, we don't want them to separate, and that's what a desmosome is. And I drew it like kind of like a chain link to remember that all it does is hold them together. And so these two aspects together are called the intercalated disc. Okay? So then we'll go over how a contractile cell works. This one sits a lot lower. Its resting membrane potential is at, this is -90, right? And then its threshold is around -70. And it'll get to around +10, +50. I was gonna say +15, but +10 is accurate. And then it'll go, kind of go back down to 0, and you'll see how that kind of works. Okay, so what kicks off this cell? What kicks off this cell is kind of our normal voltage gated sodium. This is our voltage gated sodium, and that takes us our voltage gated sodium is triggered by, like I said, from the bong of the pacemaker cell. So this is from the pacemaker. It reached threshold, and now we reach our kind of +10 area, which is then going to, believe it or not, go down for a sec. So this is our sodium coming in. I'll draw that here. And then that part where it comes down is potassium's like, oh, you know, the cell is depolarizing really fast. I need to do my job. I'm gonna let potassium out. Also, what happens is chlorine goes out, or chlorine goes in to make the cell a little more negative. But what's interesting here is we have that darn L-type calcium channel again. This is our L-type. And it's going to flow in enough that it matches the current of these guys. So instead of to keep depolarizing, we're gonna have a plateau, which means we're gonna stay contracted longer there for a sec. And then eventually potassium's gonna overthrow the amount of calcium coming in, and then it'll go back down and to where it's like supposed to be. And the L-type calcium channels will turn off, and then we're back to our resting potential. So now I'm gonna get rid of that. And so this phase where it's at under threshold is 4. Kind of weird. And then this phase right here where it depolarizes is phase 0. This phase where it's rapid repolarization is phase 1. The plateau is phase 2, and the depolarization is phase 3. Okay? And so that's kind of how the action potentials go in these cells. Okay, now we're going to talk about how the parasympathetic and sympathetic nervous system affect the pacemaker contractile cells, which in turn affects the blood flow to your entire body. So kind of some important terms that we need to define before we can really get into this is chronotropy, which means heart rate. So if I increase chronotropy, I increase heart rate or decrease heart rate. The way I can remember that is there's an HR right there. So that stands for heart rate. The next one is ionotropy. That one stands for the contractility of the heart. So the way I can remember this is completely dependent on ions, specifically calcium. If I have more calcium, then I can send more signals to our troponin, which is then going to cause the muscles to contract a little bit more. So if I have more calcium, I'm increasing the contractility of the heart. Then I have lusitropy, which is talking about the relaxation of the heart. And you can remember that is loose. Relaxation means loose. Okay. Couple things to keep in mind here is parasympathetic will only affect the pacemaker cells, and sympathetic will affect both the pacemaker and the contractility of the cells. Okay, how that's going to work is we'll do a sympathetic response in a contractile cell. We have right here, this is a beta-1 receptor, which, if you remember, that means adrenergic. So that has to be kind of a that would be obviously a sympathetic response, but it has to be norepinephrine, epinephrine, dopamine, any of those adrenergic things. And what that will do is it will activate the alpha subunit, which will then activate adenylene cyclase, which will turn AMP into cyclic AMP, which will then turn on protein kinase A, which will phosphorylate, PKA, which will phosphorylate things. How that works is we have a couple different ways, a couple of different things that it'll phosphorylate. The first thing that it'll phosphorylate is it will phosphorylate the phospholamban, which there is a circuit pump in here. Or there's a SR. And in here we have a RYR, which is just a huge calcium, which will phosphorylate phospholamban, which means that circa has increased activity, which means that we have more lusitropy, which means that we can contract faster. So that's the first thing it does, is it goes phospholamban right here. Okay, next thing is, if you remember, we have, I'm just going to explain this to you because it'll take too much to draw, but we have troponin, and what's going to happen is it's going to phosphorylate troponin, which will then cause it to release release calcium, which will get it to basically stop contracting and let go, which is going to do the same thing. It's going to cause more relaxation, which means we can do less length of contraction, which means we could do that faster if we wanted to. Okay, then there's some things where it affects ionotropy. And it does that through the pKa will phosphorylate RYR. I'm just making sure I got this right. So there's something on the RIR, it basically helps it dissociate, the phosphate does. And then this is able to push calcium out, which would then increase their contractility and increase that action. And then we also have, it opens the L-type calcium channel better. And that does the same thing. More calcium means more ionotropy, which means that it can, essentially since it can't do motor recruitment, the only difference you can make on the contractile cells is how hard it contracts, which is ionotropy, and how fast it can let go, which is lusitropy. Okay, so that's how the parasympathetic system, the sympathetic system works on a contractile cell. How it works in a pacemaker cell is, likewise, we have a beta receptor and a G protein. That'll go in here. Then what happens is, essentially, same thing. We get more cyclic AMP, which will then turn on cyclic AMP turns on pKa, same thing. And then the pKa in this case causes an increased calcium influx, which that increased calcium influx will then, it makes the steepness of this slope large, makes it a little more steep. And it also makes the threshold a little lower, which means it's able to fire more action potentials faster. So it just speeds that up. The other way it does this is the CAMP will go over to our funny channel, and it'll make that open up a little better, which is also going to increase this slope, firing more action potentials. So it'll make it faster for us. Okay, last thing is parasympathetic response in the pacemaker. How will it slow down if we need it to? What's essentially going to happen here is we have I'm going to do this one in, do we have red? No, we don't have any red. I'm going to do it in this pink. This is our M2 receptor, and that gets primarily activated by our vagus nerve. That is going to then turn this is our beta, gamma, and this is our alpha. It's going to create a heterodimer with those two beta and gamma, the two beta gamma subunits. And what that's going to do is that's going to go to it's kind of like this, but it's a G protein calcium channel. That'll activate that. We get more potassium going out, which means it's gonna hyperpolarize, which means it's then gonna take longer for it to reach threshold. The other way it does this is the alpha subunit will then go over to our funny channel and slow it down. And then our calcium influx gets slower from all this, and that will essentially slow it down too. So that's how the parasympathetic response happens in that. And so I have this that you can kind of see it all together. Making it easy. Okay, this is me going over kind of the heart and the normal ECGs and what that looks like. Okay, first thing that we really need to notice here is where our pacemaker nodal cells are. Our first big one would be this guy. This is our SA node. Okay, and then right here is our AV. So what's gonna happen is the SA node's gonna send that first action potential, and that's gonna spread over here via the Bachman bundle. But it's also gonna be spreading through here over to the AV node, and that is called the internodal pathway. Okay, internodal path. What's then gonna happen is we're gonna have a little bit of a delay, and that's gonna allow for these atrium to contract, and that will then push all the blood down there, and that's what that delay's for. And then this is gonna spread down here, and this is called the bundle of His. And then it's gonna branch off. And then one's gonna go this way. And this is the left branch. This is the right branch. And then these are our Purkinje fibers. And all of these have their own timing. I'll actually tell you what they are. The timing for the SA node is about 100 beats per minute. The AV is about 40. Purkinje is about 20. And so SA node's the fastest, so that's why it's called the pacemaker of the heart, is because when that goes off, it will cause everything else to go off. And so the way that we monitor this, we monitor it through an EKG, which is when we have a negative electrode and a positive electrode. There's 12 of these leads, but right now we're only gonna focus on lead 2. And to show you how this works, I have a heart. So, this is the front of the heart. These are our atrium, these are our ventricles. And what happens is, we squeeze this side, and it spreads down this, kind of down our pathway here. And what's gonna happen is when we depolarize, we're pulling positive into the cell, which means the outside of the cell is getting more negative, which means we have a vector that goes like this. It's pushing negative towards a positive. And what that looks like on an ECG is a upward stroke. Versus when we send a negative towards a negative, that would be a downward stroke. So we have this, and then our SA node sends it, and it depolarizes the atrium. And that is our P wave. And then our AV holds it for a sec, and there's no separation of charge right now, so it's gonna be flat. And then it's gonna come down this, but then it'll, since this left branch is bigger, it'll send via gap junctions to the right branch, which means we have a vector that goes like this, which is sending negative back to negative, which is gonna give us a downward stroke. And that is our Q stroke. But then as it continues to go down to the apex of the heart, we get this huge upstroke. And that's our R stroke. And then eventually, it's gonna start to go this way. We're gonna have another vector going out, which means we're gonna get a downward stroke. And that's our S stroke. And then the whole thing is gonna be depolarized. And we have a little break. And then what happens is on the outside of the heart, which would be this, the outside of the heart is called the epicardium. Then we have the inner muscle, that's the endocardium. What happens is this epicardium is the last to depolarize, but it's the first to repolarize. So it's gonna go like this and kind of flip a U-turn, and now it's gonna repolarize, which means that the cell is gonna push positive out because it's pushing potassium and stuff out, which means we're gonna then get a vector that goes like this. But this vector is pushing positive out of negative, which means we get an upward stroke. And this one's a little bit bigger. This doesn't do it justice. This one's a little bigger. And then it can do it again. And that's our T wave. Okay, kind of last thing. We'll be talking about our abnormalities in our ECGs. Okay, something that happens when we get a lack of oxygen, which happens because on the outside of the heart that we have here, on the outside of our heart, we have our coronary artery, okay? And our coronary artery, what happens is it gets a blockage, okay, right here on our left side. And when that gets blocked, what happens is this wall right here can't get enough oxygen, which means it can't repolarize because of our ATP and stuff. And so when it's not able to repolarize, we have a response, which is our body says, okay, we're not getting enough oxygen. This isn't repolarizing. There's a channel that opens up. It's called our potassium ATP channel, which is really triggered by the ratio of ATP to ADP, and so too much ADP will cause this channel to open up. And when that opens up, it makes it so the endocardium, which is usually like this, and our epicardium usually follows behind it and then repolarizes first. It makes it so our endocardium repolarizes first. And when that repolarizes first, that means it's sending in the repolarization, which means the inside of the cell becomes more negative again, right? It's more negative. And then our epicardium becomes more negative. It's already negative, which sends a negative signal that way, which will then invert the T wave, and the whole thing looks like it's upside down. So that's what happens when we have slight hypoxia. Then what happens is we get a bigger blockage. And that bigger blockage will cause this whole, I'm just gonna say this inferior lateral section. This whole section won't be able to repolarize, which means this stays positive, the outside of this stays negative, and we go sending like a constant negative towards positive signal. And that is what we call an end-STEMI. An end-STEMI looks like this. We have our normal QR, our normal ECG. It's literally just way higher because it's constantly sending this signal. And then it goes down to normal, stays here, and then goes up the T wave and stays. Because now it's trying to repolarize that spot, never repolarizes again. So that's what this is our end-STEMI. Then we get what's called just a STEMI. It's a STEMI, okay? And that's when everything from here to here can't repolarize, the entire wall, which means this is all more positive, which means if this is all more positive, it'll be sending a signal back this way, or a negative signal that way. We get it'll be sending, a negative signal back towards the negative, which means it looks lower than it should be. So then it does its QRS. Then it comes down, and then it stays where it's supposed to be. And then when it repolarizes, it goes back down. And that's our STEMI. Okay. We're gonna go over the cardiac cycle. I'm gonna do this on my iPad because I don't want to draw out all these little things to show you. To me, this is an easier way to look at it than here's the graph they give you. Before I explain that to you, I'll explain this. Systole means contraction. Diastole means dilation. And so the first thing that happens is we get a rapid inflow right here. And that's just when our AV valves, the pressure in here, in our atrium, gets so much that these AV valves open, and that allows the blood to come in. And that's a rapid inflow. The dialysis is when most of this comes in, it starts to slow down. And then our atrial systole is when the atrium squeezes to get kind of the last little bit of that blood out. And that represents our P wave, right? Because that's our atrium squeezing. Then we have our big systole. This is our isovolumetric contraction. That's when our ventricles right here begin to tighten up. And when the pressure of the ventricles is greater than the atrium, the AV valves right here, they'll close. And they're kind of like a latch because once you start putting pressure that way, they'll close even tighter. And that's what gives us our lub sound. And that also happens when these are contracting, which would make sense that it goes with our QRS complex. And so finally we're left with the ejection. Now our pressure from the ventricles has gotten more than the pressure of our aortic and our what's it called? Our veins and arterial, place. So then these push out and these SV valves open because there's more pressure. And so when the pressure the SV valves open, and then when our ventricular pressure is low, it starts over again. But when these SV valves open, that's what gives us our dub sound, right? And that's also our repolarization. So that's kind of cool. And that's how the cardiac cycle goes. As you see here, we have the correlating action potentials from our ECG that we just learned. So it all comes together quite nicely.